you all hear me from there? So, welcome everyone to this course, and it's always a pleasure to speak at the SASO Asia courses. I've always enjoyed speaking here. It's a wonderful program. I'm sure you've seen all the lectures and the distinguished speakers. So it's, I'm sure hopefully you will benefit a lot from this. It's also wonderful to see so many old friends here, some of whom probably shouldn't be here actually. I'm sure you know more than me about this. So, but again, great to see everyone here. Before I begin, of course, I'd like to thank Adrian and the organizing committee for inviting me to speak here. And of course, to all of you for coming here. You know, if I ever get boring, please feel free to just go and get a drink or something. But hopefully, we can learn together on some of the points that we'll be discussing. If you have any questions, like Adrian said, please just feel free to ask, either during Q&A or even interrupt. Maybe if I've got the wrong diagnosis, try and tell me quietly. But short of that, please ask and let this be interactive. Okay. So, well, for good or for bad, you're kind of stuck with me this morning. And I'll be starting off on the first lecture on the principles of OCT-Angiography and how this can apply to retinal diseases. Now, OCT-Angiography is something that is of course available now, but it's only come out in the last few years, and it's a technology that we are still learning about. It's exciting, it's very useful, but I think we still have much to learn about this, and we need to be careful how we apply this. So firstly, I'd just like to acknowledge some of my colleagues who have contributed to this, and also my financial disclosures, but none directly relevant to this. So OCT-Angiography, if you were to look at this at first glance a few years ago, you would have guessed that this was an angiogram, perhaps a fluorescein or indocyanine green angiogram. But no, this is performed just using OCT. There's no dye injection, there's no other, you just use the OCT instrument itself, right? And so this is what's exciting about this. What are the limitations? We're used to fluorescein angiography, indocyanine green angiography, right? And I believe that this still has a big role in the practice of ophthalmology, but there are limitations. Firstly, availability. I know that not every center has both FA and ICG. In fact, I believe I've been around the region. Some regions, some countries don't have, for example, ICG, and so we've talked about polypoidal choroidal vasculopathy and how I'm frankly very keen to learn more about how you go about diagnosing that. But you know, it's something that's useful in the patient if you don't have ICG available. Doing a conventional angiogram, you need intravenous access. So that means you need to insert a cannula. Of course, that can cause problems, although that's usually not a big thing. There's a small risk of allergies to the dye. The investigation can be costly as well, and it takes time because the entire angiogram will take at least 20-30 minutes, depending on how long you want your late phases. So these are all factors that you have to take into account, especially in a busy practice. So what are the benefits of OCT? Firstly, it is rapid. It is a lot faster. You can get a scan in a few seconds. It's non-invasive. You don't need to inject the dye. You don't need the cannula. You can look at it qualitatively, but you can also quantitate something such as blood vessel density, and it gives you a better detail of the microvasculature, better than, for example, fluorescein angiography. Also, it can show the vessel content and not the wall. So this gives us a better idea of the blood circulation. And very importantly, it's got depth resolution. So we're able to image different layers of the retina, as you'll see, and see the vasculature in each of these layers. Whereas with fluorescein angiography, for example, the vessels are actually overlapping. So you actually get a composite of all the images, and you have to sometimes try and discern which layer it is. That, by the way, can be overcome partly by the use of stereoscopic angiography. If you do a stereo PET, that can give you an indication, for example, where the leak is coming from. But we'll concentrate on OCT angiography. So as I mentioned, there are different layers. You can have the superficial vascular plexus in the retina. There's interconnections, the intermediate capillary, and the deep capillary. So, whereas on the fluorescein angiogram, all of these layers are superimposed together. In a OCT-A, you can separate them. In addition, you can also visualize the choriocapillaries, and there's a lot of work on characteristics of the choriocapillaries in terms of flow voids and other factors, and how this may be relevant to both health and disease in the eye. And if you go deeper, you can actually visualize the choroid. This is not an ICG angiogram. This is the actual OCT-A. So it's quite impressive. And you can have different fields of view. This is 10 degrees. This is 15 degrees and 20 degrees. And of course, some devices can go wider, 12 millimeters by 12 millimeters, and you can montage and stitch together different scans in order to cover a larger area of the retina. But do be careful, this is one limitation. This is only a very small region of the fovea, of the macula, and therefore you will not be seeing things outside there. Right? So that's something to think about. If you're looking for a very widespread disease, then OCT-Angiography needs to be taken with a pinch of salt. So, OCT, as you know, provides structural detail, and I'll be talking a bit about the pearls and pitfalls of OCT interpretation later. But OCT-Angiography, as I mentioned, is able to visualize not only the anatomy, you do have those in cross-section, but also the actual vascular flow within this area. So it gives us additional information. So let's look at some examples of how this is applied. For example, age-related macular degeneration, a common problem I think in all our societies, all our populations, and something that's going to grow with the aging population. So conventionally, we're used to fluorescein angiograms, and those of us who are a bit slightly older, so I'm finding no Adrian's age. He mentioned it's between 35 to 40, right? So disclaimer, I should state also that I'm younger than him, so then that makes me even younger than that. I'm very happy. You know, maybe 18 to 25 range. But essentially, for those of us who remember, all right, we learned, and I'm sure we still learn, about the different types of leakage on fluorescein angiography, your cult leakage to classic, and then there's minimally classic, and so on. All right, and those definitely were very useful in classifying groups of AIM lesions. But with OCT angiography, we need to think of something different, because OCT angiography does not show us leakage, so we cannot comment on leakage. We see the vessels, we don't know whether they're leaking. That's a very important point. ICG angiography is also something that we're used to, and it shows flow in the choroidal vessels. So we usually look for PCV, for RAP lesions, and it certainly is useful. But again, you need the injection, and ICG especially, I know, is not always available in some centers. How about OCT? OCT is wonderful, an essential tool for structural features. We can see this in great detail, but again, as I mentioned, it is a static image. You do not see activity. You do not see the vessels. So this is an example of activity on OCT, and which you need to correlate with the fluorescein angiogram. So on OCT-A, different patterns have been described, and this is a paper by Koskas a few years ago describing the different patterns of OCT angiography. So this are some of the terms that have been used, and I'm sure maybe some of us can either come up with more creative terms or even local terms that we're more used to, in the context of our cultures. But they describe a lacy wheel, filamentous linear vessels, a medusa, a sea fan, a dead tree. And I'll show examples of some of this. Now, why is that important? Well, as I mentioned, we're still trying to understand OCT-A, and so when we're beginning, we're trying to see patterns. We're trying to see what's the difference. How does this one eye look different from another? And I'll show that some of these features may have prognostic significance. So this is described as a lacy wheel pattern. I apologize for the image quality, but this is the best I could get from the article itself. But it looks like there's a lacy pattern, long filamentous vessels, numerous branching vessels, a few large mature vessels, a dead tree appearance. Now, actually, frankly, I'm not sure how it is different from this one, right? Okay, okay, fine. But I presume it's trying to represent something like this. Okay, and then there's the sea fan, something like this. A Medusa, I deliberately withheld showing a photo of a Medusa here. Okay, and even this has been described as a glomerulus appearance, which, if you remember anatomy, looks like that in the kidney. Okay, so not something that we don't worry about too much. So how is this useful in AMD? Well, this is an example of a patient where you focus and you see leakage on a fluorescein angiogram. But with OCT angiography, you can identify the lesion and you can also isolate it in some cases if you have segmentation and are able to view specific layers. All right, and in addition, you can see other features. For example, there's been described as an area of hypoperfusion in the chorocapillary beneath the region of a CNV lesion. And this has been discussed as a potential prognostic indicator. So these are things that you can see very clearly on an OCT angiogram. And so I mentioned criteria for activities. So Koskas, using the same paper, described features that they considered indicative of disease. So this goes by shape, the lacy wheel and the C-fan, the branching. The more branching there is, the better. Well, the worse rather, because it seems to indicate activity. The presence of anastomosis and oops, vessel termini, and a perilesional hypodensity halo, which is what I mentioned earlier, like so. So these were deemed to be indicative of disease activity. And they found that when a patient had 3 or more of these, 95% of these lesions were judged to require treatment. This was a study where they actually decided whether the patient needed treatment or not based on other criteria, and then they looked at the OCT and they found when 3 or more of these lesions were present, 95% of those cases were judged to have required treatment. Whereas if it was less than 3, 90% were judged not to require treatment. So that's quite good correlation with the clinical judgment. Okay, so, and it highlights the correspondence. Of course, that's in one center based on their experience. It may, of course, vary. It can be used for monitoring as well. So this is a patient reported with type 2 AMD. You can see this on the conventional angiograms. And you can see very clearly the patterns. This is of the CNV lesion on the OCT angiogram, which is nowhere as clear on the fluorescein. Right, so you see this, and they used it to monitor over the course of treatment. And you can see that the size of the lesion as well as the density of the vessels changes over the course of treatment. And they were able to measure this both by lesion area. There's also the vessel density, which is really just a ratio of the pixels of the vessels to the entire region of the scan. And obviously, there's quite a big change in some of these. And again, though, the question remains: how useful? How big a change do we care about? So, for example, let's look at this one: 1.77 to 1.64. Is that relevant, or is that just something that's a slight variation? Right? Because if you measure it slightly differently, you're going to get a different value. So this is what I mean by there's still a lot to learn. How big a change are we looking for? So this is, I'd like to share maybe 1 or 2 examples of how this may be useful in AMD. So this is one of my patients. You can see a bit of a subretinal scar. She's an AMD called leakage. And in December, when I saw her, she was well. There's on the OCT, there's no leakage. But a few months later, when she came back for review, even though the vision was good, there was leakage. But this lady is chronically afraid of treatment. She is terrified of injections. She refuses to be treated. But I was concerned about the fluid, and I was trying to just persuade and convince her that this is active. And so she said, well, but there's something black there, so what, right? So I did OCT angiogram, and I showed her that there's this lesion that lights up. Okay, and remember, there was no need for fluorescein or indocyanine green for this. I just did OCTA, a few seconds, and I showed her the image, right? So the ending of the story, she still refused treatment, and she's refused to this day. But at least she was convinced that, okay, I see there's something there. So that's how it's potentially useful. Incidentally, her vision, she fluctuates, but her vision is still like 6/9 or something. So, okay, I guess it's fine. Okay, so and in the outer retina, you can sometimes, it depends on the layers. So there's auto segmentation, and devices are now having many more layers of segmentation. Again, something we need to learn about, because if you segment at a certain layer, and if you don't look, if it's not correct, you're going to miss it. So let me give you an example. What if I drew a line from the floor to the ceiling, and you can count how many people there are in the room, then you'll know it's obviously a very good turnout. But what if I drew the boundaries from the ceiling to here? Then maybe you'll count myself and a few people who are standing, right? All of you will be below that layer, you'll be missed. And if you drew something above my head, and no, I'm not that tall, but still, from my head to the ceiling, then the machine will tell you there's no one in this room, which is not true, right? So that's an indication of how important segmentation layers are in OCT-Angiography. There's advantages that we have more layers, but it's also important to understand what layers we're looking at, and to make sure that the layers are drawn correctly. Don't assume that. So here's a case of a diagnostic dilemma. This patient was referred to me by one of my colleagues with a bit of RPE changes in the retina superiorly. So there's this OCT that was done showing subretinal fluid and very thickened choroid. You know, you see the lower boundary of the choroid there. And superiorly, there's a bit of RPE elevation. This was the autofluorescence showing hyper-autofluorescence in that region with a bit of hypo. I think some of you can probably shout out the diagnosis already. But is this CSCR? So that was the question to me. And you know, if I had just seen this patient in my own clinic, I would have said, CSCR, right? I mean, well, of course, there were other features. Trust me, I'm just showing you examples. I'm not that cavalier with my diagnosis. But we looked through carefully, we examined the patient, there was no other indication. But when a colleague sends to you, this was a consultant from another subspecialty, sends to you and says, is this AMD? The pressure goes on you, right? Because you don't want to be wrong, right? And you know, they sent to you for a reason, right? You know, so what did I do? Well, let's look at the details of the angiogram. You see some areas, but it seems to be a bit of perhaps leakage there. In fact, that was why there's this confusion. Okay, and it's perhaps not as pinpoint. You don't see the classical ink blot or smokestack here. Although we later decided this may be a bit of a mixed type of leakage. On the ICG, nothing specific. Definitely not PCB. Don't see anything very specific. But is it early, a small CNV lesion? Do we need to be concerned? Well, this is the OCT-Angiogram. But remember, I told you, this is a 6x6 millimeter. The region is probably a bit up there. You might see part of it, but not all. So it's important to know the range of your OCT scans. So we steered this upward. You can see the fovea is down here now to cover that region. Excuse me. And we found that there was no activity. Okay, so it's a bit more reassuring. Frankly, clinically, based on my judgment, I would have said CSCR. Even if it's an AMD, it's very low activity, I would have watched it. But this gives an extra reassurance. Okay, so you're using this and to help you get more information. As I'll mention later during multimodal imaging, that by its name tells you how important it is. And even with OCT, one of the pitfalls is, I will mention, is do not rely just on OCT. There's no need to rely on just one modality. How about polypoidal choroidal vasculopathy? I think some of you know that this is my area of interest. And of course, this is something that we see very commonly in our region amongst Asians, much more than in, say, Caucasian populations. So, and the relevance, of course, is the frequency of the PCV amongst AMD patients, anywhere from 22 to even 55% in Asians, compared to at lower numbers, even single digits in Caucasians. And PCV presents in a variety of ways, so that's something that we also have to take into account. There can be hemorrhage, but sometimes it can just be quiescent orange subretinal nodules as well. So this is a disease that sometimes has fooled people before. Now, the key feature and the gold standard for PCV is still ICG angiography, and this does, in my opinion, does not change. Right? There are some who will diagnose PCV on OCT. If you have no choice, I mean, if you do not have ICG angiogram or your machine is broken down, you have to do something. I understand that. but I'm saying that there's some who will say, I have ICG, I'm just not going to do it because I can do it on OCT. Well, I would like to learn from them. I'm sure there are some points, but I can tell you that looking at features on OCT, I've been wrong. Okay? There have been times when I look at OCT, I think that's what we get first, and I tell my resident, this is PCV, see this thing here? Send for ICG, and guess what comes back? Nothing. Okay, and I look like a total idiot. Okay. At other times I say, nah, this is not, I don't think so, but okay, fine, let's do an ICG. And it's polyps everywhere. It's like, oops. Okay, so, right, so, I mean, an obvious PCV is fine, but sometimes it can be subtle, right? So I believe that if you really want to be sure of diagnosing PCV using the standard definition of PCV, you need an ICG. I don't think that has changed yet, but OCT-A may show us some interesting features. So first, how do we diagnose PCV? Just a quick run through. This has been described, the imaging characteristics on the Everest study. Basically, we look for early focal ICG hyperfluorescence, plus one of 6 criteria. 4 of them ICG based, 2 of them are based on color fundus photos. Okay, so let's run through briefly. On ICG, you are looking, you need, at least for the Everest study, you need a stereo pair, and you're looking for a nodular appearance. Just because it's bright on the ICG angiogram doesn't mean it's a polyp. It could be round and bright. There are other things that can appear round and bright. But it's nodular, that gives you a stronger indication. If there's a halo, a hypofluorescent halo, I think the image might be a bit small, but you can see around this hyperfluorescence, there's a dark halo around it. The presence of a branching vascular network, or on a dynamic angiogram, if it's pulsating. These are indications. Or you can see an orange subretinal nodule, and finally, massive submacular hemorrhage, like so here, where it's defined, at least for the Everest study, is 4 or more disc areas. This is obviously much larger than that. So ICG hyperfluorescence in the early phases, plus one of these, by this criteria, is sufficient to diagnose PCV. So remember that when we talk about PCV, we're talking both about polyps as well as the branching vascular network. And the branching vascular networks can be different. Some of them are more obvious, where some others are very subtle, shown by the white outline. They can be quite faint. Right? This is what we term interconnecting channels. But there are also abnormal channels that supply the polyps. So some authors have described using OCT-A on PCV, and we've also looked at this in our center. And this is what we found. In summary, OCT-A is better, or at least as good as ICG-A when you're looking for the branching vascular network. The margins are well defined. You can see the individual vessels, and I'll show you examples of this. So if you look at this is the indocyanine angiogram, but look at the OCT-A. You see something here, and I agree this is probably a late phase of the angiogram, but you see something here and you say, well, okay, polyps, and maybe something, the branching vascular network, right? So clinically, I will be willing to call it like so. But if I look at the OCT-A, I can actually see the individual vessels, so it's a lot clearer. Okay, another example, polyps, and some region here that looks a bit unusual. But look at the OCT-A, you can even trace the vessels, right? If each of us took this photo and drew it out, I think it would be fairly consistent, depending how good our artistic skills are, right? But for this, I'll get 60 different answers, right? But also notice, large polyps, and this is the region where the polyps are. So that's one of the things. We don't see polyps as often on ICG angiography. Another example, polyps, but nothing on the OCT-A. These are the regions where the polyps are, the corresponding regions, and you do not see it. Okay, so that's very important.
Which segmentation layers are these?
I'm sorry, say?
Which segmentation layer is this?
Okay, so this would be what we call outer retina. This is using the opto view, and this is the probably choriocapillaris layer. Yeah, but generally you will find that they tend to be in the choriocapillaris or the outer retina layer. But that's partly because of segmentation. It's not technically in the retina itself. Okay. So, as I mentioned, visualization of polyps on OCT-A based on these reports is about 50%. In our series, we found about 70% we could identify the polyps, but that's probably not good enough. Right? So how does this limit us? If you do an OCT-A, you might miss polyps in at least, if you look at it, from my experience, at least 30% of cases. That means you will not be able to confirm that this is PCV. All right, if you just see this, how do you know this is PCV? Why is this not AMD? All right, but you know, do you suspect it? Are you then going to say, well, but I see an orange nodule there? Well, you can, but you don't have that confirmation. And secondly, if you were intending to do PDT for this patient, combination therapy, PDT and anti-VEGF, where would you laser? Where would you apply the spot? You can do so presumptively, right? You can, but is that what we want to do? So that's the limitation of OCT-A in this sense. Okay. So this is an example of one of my patients. The ICG angiogram shown here, and the 4 layers, you asked about segmentation. So this is the superficial layer, looks perfectly fine. Deep layer looks perfectly fine. But see how nicely the small vessels are seen on the OCT angiogram. You don't see this on FA. Outer retina, a hint of something, but this is where the lesion is seen. The branching vascular network and the polyps correspond to this area. I tried to just show the two of them, and I tried to have the size roughly equal. You can see here, here's the branching vascular network ICG. Those of us who are familiar with PCV, you know this, we all agree, it's a BVM. But look at this, it's a lot clearer. And in this case, you can see, well, yeah, some polyps, sure. All right, which is good. And so you're probably thinking, oh, what are you talking about? I can see the polyps there. First of all, I know it's a bit cut off, but perhaps there could be another lesion here, which is not so well seen on the OCT-A. But let's look at this other patient. This patient has a chronic PCV, and he always has this hemorrhage around this region. And on the ICG angiogram, you see something hyperfluorescent. Trust me, it's nodular in appearance. And on the OCT, it has a typical appearance. So I deem that besides this one, there's a polyp there as well. Anyway, it's bleeding. But if we look at the OCT angiogram, of course, the retinal layer shouldn't show anything. Again, you see the BVN, but you don't see the polyps. You don't see it at all. All right, and we even steered this lower inferiorly to look for where the PED is, and you just see a dark region there. You do not see the polyps. So if I were going to treat him, how would I know? Would I treat it? Would I treat this and call this PCV? And even if I say, well, putting everything together, I think it's PCV, where do I apply the PDT spot if I want to do it? If I'm going to give anti-VEGFs, then that's fine. All right, that's one option. But if I'm giving anti-VEGFs, then maybe some would argue that, or have argued that it doesn't matter then what the lesion is, although I may not entirely agree with that. Right, so again, another patient of mine, nice juicy polyps, absolutely nothing on the OCT-A. So how about diabetic retinopathy and DME? So we're going on to retinal vascular conditions now. Now, this is something that I think OCT-A, obviously, you would think would be very useful because it looks at the retinal vessels in great detail. So remember, there's a superficial and a deep capillary plexus in the retina, and indeed, there's also an intermediate one. Some devices can separate the intermediate from the superficial and deep, some don't. I'm sure this will change as both our understanding and technology improves. Also very important, there is a variation of FAZ size. Okay, so be very careful. Just as there are different heights, different weights, different ages, in this room, there are different FAZ sizes. So I'm assuming everyone here has normal eyesight and normal eyes. But if I took each and every one of you and did an OCT-A, yours could be like this. And don't worry, there's no FAZ, hardly any FAZ here. Don't worry, it's still, that's normal. It could be this, it could be even larger than that. And as far as we know, the eyes are normal. There's no pathology. Okay, so there's a large variation in FAZ size. Right? So we did a review of this, and we found that the range can be from 0.04 square millimeters to 0.4. It's a 10-time variation, right? So if you find something larger, a larger FAZ, think it could be related to the fact that this patient may have a larger FAZ to start with. All right. Conversely, if someone has a normal eye, his eyes when he was normal had this FAZ, by the time it enlarges to this, you say, oh, that's just a medium size. But no, that's huge compared to this. It could be diabetic retinopathy, for example. But in general, they found that those eyes with DR have a larger FAZ compared to healthy eyes. But it's more than that. If you look at the other vessels here, you see that there's areas of capillary dropout, much as you would expect in a fluorescein angiogram. Okay. But that's again one of the caveats. OCT-A is very sensitive to image quality. Right? For OCT, of course we want the best quality for everything, but you can get, when you have problems with the quality of the OCT, you will get areas of dropout. So if there's something that's not right here, I mean, this could be an area of dropout. I'm quite sure this is, frankly, I will bet on it. But this area, it could well just be the quality, especially at the periphery of an image. Right? So that's one of the limitations, which is a bit unlike a fluorescein angiogram. So if you were looking at a fluorescein angiogram, you say, I'm sure this is area dropout. But on OCT angiogram, can't be sure, it could just be image quality, although it does seem to be a fairly good image. All right? So they found that the FAZ area increases correspondingly, and this is both horizontal and vertical diameters. I'll just mention that many devices don't allow you to measure this. Some, like the OptoView, do, but it's like a bit of a dropper tool for those who use Photoshop. You just touch it and it just fills up a whole area. If you want to measure it using your judgment itself, you need to use third-party softwares to draw it out. Obviously, in a busy clinic, that's not very likely to happen. All right, but this is an example of showing examples of normal eye, mild, moderate, severe. All right, and you can see that you can see the FAZ is regular. It gets increasingly irregular. I think that's more important really than the size. You can see the edges are irregular, and there are increasing areas of dropout. Okay. So this is just the descriptions based on this study in graphics, the article. But essentially, I think qualitatively we can appreciate this. What's challenging now is, of course, to try and correlate this with how we're going to manage this. We can also see microaneurysms and ermas. So this is something that is not as well seen sometimes on a fluorescein angiogram. Especially remember in the late phases of or late, even mid phases, it starts to bleed, right? So that's when you will see it so clearly. You need to get a very early fluorescein angiogram. But one caveat again is that studies have shown, like Giovanni Storangi has described and shown examples of cases where fluorescein angiograms and OCT is done same eye, same day. On one, you see areas of microaneurysms, on the other, you don't. But it doesn't mean that one misses out and the other takes out. It just shows some here on the FA, some there on the OCT-A, and you don't see it on the other one. So which do you believe, really? Are you going to do both and integrate them? Are you going to take one? So these are the challenges that we face right now when we talk about OCT-A. Right. So again, even more florid examples of this. Right. But those who have tried repeatability have shown that there's good repeatability for vessel density and FAZ size. Remember though, a lot of it depends on the quality of your image, and Srinivas Sada and his team have shown that ideally you should take multiple scans and then do a composite of them, and then then it gives you even a better quality and more reliability, which is great. And I'm sure in a way that may be one way to go, but obviously at this point that's still experimental. So he has a whole army of fellows who will do that for him. But in the clinic, right? We can't do that. Obviously, we can't even take two. We don't even have the resources to take 2 scans, much less get someone to do a composite and process it. It's going to take too long. Patient not going to wait. So something to know and remember. How about retinal vein occlusions? Well, again, you can see very nicely the superficial and the deep. This is a branch retinal vein occlusion. Look at the areas of capillary dropout inferiorly, all right, and also look at the vessels, all right, how clearly it is seen, right. So this is obviously quite good, but remember, if you wanted to assess, for example, you're thinking of doing a laser because you want to assess how much ischemia there is, realize that you don't know how far this extends on this edge or here, and for all you know, there could be some area up there that's another branch that's included as well. You won't know. This is a small area. This is probably a 6x6, but still, that's a small region. If you're looking at the macula alone, that's fine. But if you want to look, at the entire retina for areas of non-perfusion, you wouldn't see it. Okay? So again, there could be, for example, if there were a diabetic case, there could be an area of NVs, florid NVs right up there, and we didn't scan it, you wouldn't see it. So again, what's been described will be areas of dropout, and areas of even the microvascular abnormalities of RVO. Right, so to conclude, I say OCTA is an exciting new technology. It is here to stay. I'm convinced of that. I'm excited to have it. It can be applied to clinical practice, and it has advantages over conventional imaging. There's obviously great potential for even more improvements, but I would just urge everyone to be careful in interpreting it. Do not entirely assume it is exactly comparable to a fluorescein angiogram or an indocyanine green angiogram. There are differences, and it's up to us to really try and learn what those differences are, and not make mistakes. I'll perhaps just end with this point. I was walking through the clinic one day, having I had no clinic, but don't tell my boss that. But I had just come back from an event where I was representing my department, so there was no clinic. I was just walking by through the clinic, and as usual, when you walk through the clinic, someone will catch you and say, "Hey, I need your opinion on something," right? So one of my colleagues showed me a case. Patient had diabetic retinopathy. Question was, is there sufficient ischemia to warrant a PRP? But patient was ill, could not have a fluorescein angiogram. So they did an OCT-Angio, showed someone else who was actually retinal. And I'm not saying this to put anyone down, but I'm just going to show you what I mean, how we have to be careful. And the finding was extensive ischemia. Please go ahead and do a PRP. So I said, well, okay, you want me to have a look? I can have a look. I called up the image, and I should have kept an example of that. There are other examples. Yes, it was dark. You don't see the vessels that you see on what I showed you. These are the best examples of what we have. But what was that? It was an ungradable image. It was full of artifacts. The patient couldn't hold his eyes still. And obviously, in such a situation, you're not going to get anything, all right? And indeed, there was a lot of errors. And when I corrected that, I could actually see on the small patches of usable scan that it was perfused. So at least the usable, visible areas were perfused. So question, do you PRP that? I'm not saying, well, I will say that at least I don't see a justification based on that scan. That's the key point. And I had to call my colleague who was in the laser room and say, wait, I'm coming over, let's talk. In the end, well, we didn't. They didn't. But of course, it's up to them, right? I mean, ultimately, clinical decision. But in the end, yes, it was not laser. But realize the difference. And I could be wrong, but although as far as I know, the patient didn't develop NTs. So I could be wrong, but the fact is, this is how you can have two very different interpretations of CTA, all right? And how it could totally change your management, all right? In my opinion, that was just a very poor scan. Through no one's fault. There's a limitation of the patient's ability to cooperate. He was ill, remember, he can't keep still, as well as the technology as it stands today. So be very careful. Okay. All right, so thanks very much. Any questions or comments, please? I'll be glad for any of you to share your experiences as well. I'm sure you've also used OCTA. Please share your experiences, and you could potentially refute some of the points I made and say, nah, that's nonsense. Perfectly fine.
Sir, how do we differentiate hemorrhages from actual capillary drop-off in the OCT?
Yes. So the question is, how do we differentiate an area of hemorrhage from capillary dropout? That's a good question, and you bring up a good point. OCT, as you know, uses light waves. And so light rays. So basically, hemorrhage or any kind of opacity will block the transmission of light. So what you need to do is you will need to correlate this clinically. And same with the fluorescein angiogram, the hemorrhages will not respect vessel boundaries. It will spill over. And if it corresponds to an area of hemorrhage, then it's more likely. But you're right, there can be areas of obstruction if the hemorrhage is sufficiently thick.
I'm from India. Very nice presentation. I would like, if you have some pictures where you differentiate the active and the inactive. It would be a great help if you could show us some pictures.
Okay.
On the OCTA, you enlisted some features which suggested activity.
Right.
But what about those which do not need treatment or inactive?
Right. So that's a good question. Unfortunately, I don't have any full images here, but perhaps I could just share some of my thoughts on this. There's of course the criteria that Koskas described about the type of lesion, and I think he's shown that in his team's hands they can be quite quite indicative. I would of course correlate this with other factors, namely obviously the patient symptoms. If the patient symptomatic, is the vision dropping? Clinically, do you see anything? And of course, on the OCT, the cross-sectional OCT, do you see activity, right? So, and I'll put to you, you bring up a good point as well, that some people have done OCT angiograms on dry AMD, and they pick up lesions. So, and of course, some of them will say, well, tada, this thing picks up something new that I was missed, blah, blah, blah. But are you going to treat them? They have not. Usually when that question comes, then it's usually not a very straight answer after that. And I think it's a real thing, right? If I grabbed one of you and did an OCT-A now, as Adrian mentioned, we did actually have one course where the OCT-A machines were at the side of the room. If we did that and we see something suspicious, what are we going to do? Presumably you're asymptomatic. There's no fluid on OCT. Your VA is 6.6. Are we going to treat it anyway? So that's a point. I'm not sure if I don't have very good examples studied here, but I'll see if I might be popping in the next few days, even though I'm not scheduled to talk. I'll try to bring some if we can talk over tea or something. Any other questions? Anyone has any experiences with OCT? I'm sure some of you have tried it. Anything you'd like to share? Yes.
We have the top on OCT and using that for the last year and a half, and we recently got the Heidelberg.
Okay.
I think which would be getting installed as we speak.
Wow.
So I have no experience with that, but we've been using the top on for a year and a half. We do a lot of uveitis work at our clinic at the center that we're at. So a lot of the work from our center has been in uveitis. But as far as retinal disease is concerned, I think we use it a lot for diagnosing and following up patients of JFD or PFD, whichever way we want to call it. And as far as retinal disease is concerned, we don't do as much for DR, for diabetic retinopathy. I think primarily because most of the patients that come to us have clinically very serious disease as it is. So it'll either be screening CSME or PDR HRC, in which it's not going to add too much the OCT-A, but we do use it quite a lot in PFD patients.
Right. Thank you. Yeah, I think that's a good point. It's a very clinically obvious. For example, in DR, if we had CSME or PDR, we normally do a fluorescein angiogram. You see the vessels, you see the pre-retinal hemorrhage or even VH, right? You wouldn't need an angiogram for that. But you're right, PFD, and I think PFD is useful because, as you know, it leaks very fast and early on FA. And that's one of the advantages of the OCT-A, where there's no leakage. It's good and bad, right? It means you don't get masking from leakage, but on the other hand, in some cases you don't know whether it's actively leaking or not. Yeah, very good point. Yes.
Usually the OCT that is associated with the OCT-A is of very low resolution.
Yes.
So in your clinical practice,
Yes.
do you always have the HD OCT done first and then you progress to the OCT-A, or is it that you totally rely on the OCT-A?
Yeah, good question. So no, I would not rely on the OCT-A alone. I would definitely want the typical spectral domain or subsource OCT, the structural OCT as it were. I use the Heidelberg, right? So I would definitely want that. If there's an indication for an OCT-A, then I will ask for it. Or if I had pre-planned this as a follow-up patient, I may have said do both at the same time. But I would not rely on the OCT-A, even on the same device like the Heidelberg, the Triton. All of these have, of course, the structural. But yes, you're absolutely right. The resolution is less. I would not want to base my treatment decision based on that. But it's useful to correlate though. Yeah. Oh, really? Okay.
Yeah, maybe about 5 minutes to prepare. So
Okay, no worries.
if not, then you can go toilet, pee break or something. Then they will be available in about 5 to 10